Kuntal, you are ready?
Yes, sir, I am.
Your subject is sinus node dysfunction from bench to bedside.
Yes, sir. Good evening, respected teachers, senior colleagues, and my beloved juniors. The topic of discussion is sinus node dysfunction from bench to bedside. So, as we all know, the sinus node is a crescent-shaped structure, and it's subepicardial. Actually, it is located in the junction of SVC and right atrium. But if we go into the details of the anatomy, it has got three parts: head, body, and tail. The head is located actually in the SVC-RA junction, and in that region it's subepicardial, but gradually it becomes subendocardial towards the tail, and the tail extends inferiorly almost up to the inferior vena cava, and it contains some P cells which are specialized myocytes, and they have a pale staining property. So they are called P cells, and they are also the pacemaker cells, and there is also supporting connective tissue matrix which are involved in transmission of the impulse, but they are not involved in generation of the impulse. There are three types of P cells: spindle cells, elongated spindle cells, and spider cells. These cells have the unique property of spontaneous diastolic depolarization in the phase 4 of the slow action potential, which is exhibited by the pacemaker cells of the heart, and they discharge spontaneously, and their unique property is that the sinus node has this property that the resting membrane potential is less negative compared to the AV node and other pacemakers of the heart, so they take the upper hand in generation of the impulse. Now the sinus nodal cells, they are activated in groups for generating the pacemaker activity. It's not the responsibility of the single cell, and there is a unique thing called the pacemaker hierarchy. The faster heart rate is generated by the cells which are located near the head of the sinus node, and the slower heart rates are generated by the cells located near the lower body and tail. So there is craniocaudal shifting when the heart rate slows. The blood supply is mainly by the nodal artery, which mainly comes from the right coronary artery and sometimes from the circumflex coronary artery also. It has been shown that distension of this artery, it slows the sinus rate and vice versa. It's innervated by postganglionic, adrenergic and cholinergic fibers. Vagal stimulation, as we have seen in the cath lab, that simple pain sensation of the patient, it has got a rapid onset and offset. As the patient develops a rapid onset bradycardia, and when that pain or the discomfort is relieved, the bradycardia also goes away. But sympathetic stimulation, it has got a slow temporal response, as is occurring in a heart failure patient as he deteriorates. So let's come to some definitions. So sinus node dysfunction, it refers to a wide range of abnormalities which involve the sinus node and surrounding atrial impulse generation and propagation. So it's a dysfunction of not only the sinus node but also the sinoatrial conducting tissue. And sick sinus syndrome is sinus node dysfunction plus symptoms of sinus node dysfunction. So if we look at the etiology, there are some irreversible causes and some reversible causes. The irreversible causes, most common is the degenerative disease, age related. Associated factors are hypertension, coronary artery disease, etc. This is the most common presentation. There are some genetic causes of sick sinus syndrome as well, like loss of function mutation of the sodium channel SCN5A, which is also involved in Brugada syndrome and familial atrial fibrillation. So significant overlap occurs between these syndromes, and also the funny current encoding gene HCN, hyperpolarization activated sodium channel. Many atrial tachyarrhythmias, they are also responsible for sinus node dysfunction, and sometimes it has been seen that by ablation of the atrial tachyarrhythmia, the sinus node dysfunction also goes away. Some infiltrative disorders like amyloidosis, sarcoidosis, they are irreversible causes. Congenital heart disease, Mainly sinus venosus ASD and left isomerism, they are associated with absence of the sinus node. And in a heart transplant surgery, if atrial anastomosis is done in place of caval anastomosis, then the sinus node may be dysfunctional. There are some reversible causes which need to be excluded during the diagnostic evaluation, which are autonomic influences, very important: vagotonia, hypervagotonia in many individuals and mostly in trained athletes. We have to exclude some reflex causes of sinus bradycardia like carotid sinus hypersensitivity and some case of neurocardiogenic syncope. Ischemic heart disease, they can cause sinus bradycardia by various mechanisms. Hypothyroidism, hypothermia, hyperkalemia, raised intracranial tension, hypoxemia, severe obstructive jaundice, these are also very frequently encountered causes. Obstructive sleep apnea and sleep related bradycardia, they are also gaining importance these days. And out of infectious causes, apart from Lyme's disease, COVID has gained a lot attention regarding sinus bradycardia because of probable sinus node edema. And this edema has, and this sinus node dysfunction due to COVID has persisted for a long time, even after seroconversion to negativity. And last but not the least, we have to keep in mind the drugs which the patient is receiving, like beta blocker, calcium channel blocker, digitalis also, which slows the assay conduction, ivabradine, clonidine, etc. Special considerations, we have to keep in mind that inferior wall MI is more frequently related to vagotonia, and hence it can present not only with AV block but also with sinus node dysfunction, which is usually transient. Local metabolites accumulation is also involved, and atrial infarction, which is present in about 10% of patients, that can also give rise to sinus node dysfunction along with atrial tachyarrhythmias. Now, atrial tachyarrhythmia per se, they cause remodeling of the sinus node, caudal activation, and there can be atrial myopathy if the tachyarrhythmia is long standing, which is evidenced by a fractionated P wave, longer duration of the P wave, etc. And if we do a cardiac MRI, we will find that there is extensive fibrosis involving the atria. So the sinus node behaves in an odd manner, and there can be craniocaudal shifting of the activation of the sinus node, and the patient can be bradycardic after the atrial tachyarrhythmia episode. There is another thing called as pre-automaticity pause, which occurs after the termination of an arrhythmic episode. There is overdrive suppression of the sinus node. It has been observed that if the atrial tachyarrhythmias are ablated successfully, then the sinus node dysfunction also goes away. And genetic causes, I have already said that there is significant overlap with Brugada, atrial fibrillation, and some case of long QT syndrome. And sleep apnea syndrome is gaining importance according to the new ESC guidelines also. It's a class 1 indication to exclude the sleep disordered breathing and sleep related bradycardia. So there are high incidence of bradycardia during the apneic spells. Mechanism is mainly by vagal activation because of the hypoxemia. And there is another entity called as REM sleep related bradycardia, which is independent of apneic spells. So both the conditions are diagnosed by polysomnography. Sleep apnea is defined classically as symptoms of sleep apnea and 5 or more episodes of apnea or hypopnea per hour of sleep, or an apnea hypopnea index of more than 15 per hour in the absence of symptom. Apnea hypopnea index means the number of episodes of apnea hypopnea per hour. And CPAP has been shown to alleviate the bradycardic symptoms also, and thus it will relieve the patient from getting a pacemaker. The clinical presentation, as already said, is mostly a disease of elderly. It has equal male and female preponderance, and it has been seen that the blacks have a less chance of developing sick sinus syndrome compared to the white population. Most common presentation is disease spell, pre-syncope, syncope. Obviously, people can be asymptomatic also. Exercise intolerance and dyspnea is very difficult to elicit this history because of the aging population. They also have concomitant coronary artery disease, lung disease, diastolic dysfunction. So we can't classically point out that chronotropic incompetence is the underlying factor which is causing these symptoms, but these need to be evaluated as well. And worsening of pre-existing heart failure and angina can also occur. If there are associated palpitations, then tachybrady syndrome is definitely a possibility, and palpitations followed by syncope, pre-automaticity pause after tachycardia should be kept in mind. And because of the recurrent hypoxic episodes, there can be memory loss and early onset dementia in the elderly population. So prognosis is a slowly progressive disease, and it progresses over a time course of 10 to 30 years. It does not affect mortality directly, and the incidence of cardiac arrest or sudden death is quite low, but definitely it happens. What is more concerned, we should be more concerned, is that because of sinus pause, if somebody has got a disease spell or a syncope, then he or she can directly meet with an accident while outside, or he or she can sustain a fall and a fractured neck femur, and things can get complicated. So pacemaker therapy, if done, it improves symptoms, quality of life. It has not been shown to improve mortality, but can definitely improve mortality if these things are kept in mind. Other things which are important is that thromboembolic episodes can develop in tachybrady syndrome, and there is 50% incidence of atrial fibrillation which can develop in the due course of time, and conduction disturbances involving the AV node, they are associated in about 70% of patients. So coming to the diagnostic workup, first is non-invasive evaluation. ECG is the cornerstone of diagnosis, because once we get a sinus bradycardia or sinus pause in the ECG, then the whole diagnostic evaluation and history taking comes up. So if there are frequent symptoms daily or every 2 days, then ambulatory electrocardiographic monitoring by Holter is indicated. Exercise testing is recommended when there is symptom suspicious of bradycardia during or immediately after exercise, and when we suspect a chronotropic incompetence. I will come to this later on. Imaging, cardiac imaging is always of prime importance, because we have to exclude structural heart disease and LV systolic dysfunction, which can definitely determine the way we manage the patient. So these are class 1 indications, cardiac imaging, and cardiac magnetic resonance or cardiac CT. They are also required for specific diseases which have conduction abnormalities as a symptom. So like muscular dystrophies, these diseases we have to consider cardiac magnetic resonance also. Or say amyloidosis, sarcoidosis, these diseases. And the laboratory tests, they should include the thyroid function, liver function test, Lyme's titer, digital EPS level, serum potassium and pH. Genetic testing is indicated if there is a patient presenting with these kind of symptoms at an age less than 50 years, and there is a family member of already diagnosed patient with progressive cardiac conduction system disease. And screening for sleep apnea syndrome is of prime importance, as already mentioned. Other non-invasive methods, we don't usually use it, is intrinsic heart rate calculation. Lower values, they indicate sinus node dysfunction. It is done by achieving a total autonomic blockade with 0.04 mg per kg atropine and 0.2 mg per kg propranolol. It is represented by the formula 118.1 minus 0.57 into age. There is some variability in this range, and plus minus 14% for age less than 45 years and plus minus 18% for age more than 45 years, and it's 5 beats less for women. And if it is less than this value, then definitely sinus node dysfunction can be suspected. Other non-invasive methods, the external loop recorders, patch recorders, and smartphone, smartwatch based applications, which are now coming to our notice gradually. These are patient activated, so if there is a symptom of syncope associated with the bradyarrhythmia, then the patient cannot activate and so these these devices cannot be successful in those subgroup of patients. So the patient should be able to handle the machine. She should be educated enough to use it, and there should not be syncope as a symptom. It can be up to pre-syncope when the patient can activate the recording sequence. So the different patterns recognized by the non-invasive tests: sinus bradycardia, quite evident from the resting ECG; sinus pause, present in the ECG or Holter also. If it's more than 3 seconds in a symptomatic patient and more than 6 seconds of sinus pause in asymptomatic patient, then this is of importance, because in trained athletes and many hypervagotonic individuals, also in elderly population, during sleep it has been shown that pauses up to 2.5 seconds or even up to 3 seconds, they are asymptomatic and not of importance. So more than 3 seconds if symptomatic and more than 6 seconds if asymptomatic, then the sinus pause is important. Now sinus arrest, its total absence of any discharge from the SA node, and there is a low down escape rhythm which is evident in the ECG. And sinoatrial exit block, I will come later on. Tachybrady syndrome, chronotropic incompetence, and atrial standstill, they are all different patterns which are recognized. So let's come to them one by one for my juniors mainly, to keep them interested. So sinus arrest I have already said, and if here it is found that the sinus pause is not an exact multiple of the baseline PP interval. Sinoatrial exit block, there are 3 types: the first degree, second degree, and third degree. First degree, please refer to this picture. We can see that what do we see in the ECG? We see only the P wave. We see only the P wave. We don't see the spike, or we don't see the impulse generation from the sinus node. So if we see a first degree SA block, we cannot recognize it in the ECG because the sinoatrial conduction time is increased, but the P wave, since it is increased by a fixed amount, the P wave comes at regular intervals, and the rate is also what similar to the impulse generation in the sinus node. Only the gap between the impulse generation and depolarization of the atria, which gives rise to the P wave, this gap is increased. So the sinoatrial conduction time is fixed but increased. And now this is a very important picture. I have collected it from the internet. So this is from the original article of Shamrock. So let me explain it. So let's this second degree Wenke-Back type of sinoatrial exit block. So let's refer to the picture. The S1 is the impulse generation in the sinus node. S1, S2, S3. They are being generated at a rate of 60 per minute. 60 per minute. Okay, so the SA junction is the sinoatrial conduction time, and A is represented by the depolarization of the atrium, that is generation of, which leads to generation of the P wave. So here we can see that S1, S2, S3, they are coming at regular intervals. The SA conduction time, in the first instance, it is generating the P wave. From S2, this sinoatrial conduction time, it is increased so that the rate is decreased by some part. Okay, so it is increased, but it's not the same. So the R2, the P2, it comes at certain gap. The increment is decremental increment, which is the characteristic of Wenke-Back phenomena. So the next impulse P3, it comes earlier than expected, and the next impulse P4, it comes still earlier than expected. So the increment, had it been the fixed increment or an incremental increment, then the P1, P2, P3 will go on progressively prolonging. But since it's a decremental increment, the P1, P2, P3, P4, they are progressively shortened. So what do we see in the ECG? There is progressive shortening of the PP interval until there is a drop in a P wave. So the S5 impulse is not conducted. And here also it is seen that the pause R4 to P4 to P5 pause, that is less than the P3 P4 pause, but that is not an exact multiple of the baseline PP. Now second degree sinoatrial exit block type 2. Here what happens? The sinoatrial conduction time is either normal or it's increased but fixed. That value is fixed. It's not gradually increasing. So what do we see? We see that occasionally there is a pause because of a blocked sinus impulse, and that pause is exactly a multiple of the baseline PP interval. And if there is a 2:1 second degree type 2 sinoatrial exit block, it is exactly looking like a sinus bradycardia because we can't see the blocked impulses on the surface ECG, but they can be seen during EP stat. And third degree sinoatrial exit block, it is clinically indistinguishable from the sinus arrest. Here also there is a low down escape rhythm and there is complete absence of sinus P. But here the impulse is generated in the sinus node, it is not conducted by the sinoatrial tissue. Next comes the tachybrady syndrome. The tachycardia present are mostly atrial fibrillation followed by flutter or tachycardia and rarely AVNRT, AVRT. The bradycardia is mostly sinus bradycardia. There can be sinus pause, arrest or asystole also. The atrial fibrillation can be a slow atrial fibrillation as well. There can be pre-automaticity pauses as already mentioned. Sometimes the tachyarrhythmia management with drugs that worsens the bradycardic symptoms and makes the need for pacemaker an absolute necessity. And there can be pre-automaticity pauses which reduce after ablation of the tachyarrhythmias. Now chronotropic incompetence, it has been variously defined, but universal definition is that there is inadequate heart rate response to exercise and which is unable to meet the metabolic demands of the body. And mostly the cutoff has been set at 70 to 80% of age predicted maximal heart rate, which is represented by 220 minus age at peak exercise. And during a 24-hour halter also, it can be recognized by a monotonic daily heart rate profile and absent heart rate variability. And other patterns which are recognized are increases during initial part of the exercise and then a plateau, irregular increases, occasional decreases, slow acceleration or fast deceleration when the exercise is over. These are also patterns which are encountered. So a stress test is necessary, exercise test is necessary to establish the diagnosis of chronotropic incompetence. And a rare entity is atrial standstill because of the fibrotic atria and lack of functional myocardium. There is no spontaneous atrial electrical activity and they also cannot be electrically stimulated. So a dual chamber pacemaker won't be of much help in an atrial standstill patient. And the ECG will show a junctional bradycardia, and there is high risk of thromboembolism in this condition as well because the atria are not able to contract. Sinus arrhythmias, this is not a sinus node dysfunction, but I have just mentioned it because these are also frequently encountered in normal as well as patients with sinus node dysfunction. So if the PP intervals, usually they vary by less than 10%. If the variation is by more than 10%, then it's called as a sinus arrhythmia. There are respiratory types and non-respiratory types. Respiratory types, they are mainly mediated by the atrial stretch receptors, which are activated by increased venous return during inspiration and they increase the sinus rate. Non-respiratory sinus arrhythmia mechanism is unknown. Vagal tone, digitalis, morphine, they are implicated in this. And ventriculophasic sinus arrhythmia, they occur in a patient with high degree AV block or complete AV block, wherein the shorter PP intervals are found when they enclose a QRS complex, because maybe the ventricular contraction increases the blood supply to the right side of the heart and the SNA. Another entity which also does not require pacemaker therapy is wandering atrial pacemaker, seen in COPD patients as well, and sometimes in sinus node dysfunction. It is much like a multifocal atrial tachycardia, only the rate is less than 100 per minute. Now comes the invasive evaluation. They are not routinely done in our clinical practice, but they are gaining importance because much of the diagnostic workup is most of the times inconclusive, and many halters and patch recorders, they cannot pick up the event, and we cannot correlate the symptoms with the diagnostic findings. So implantable loop recorder, not used frequently in our country, but definitely used in the West. So this is a class 1 indication by ESC, and it is employed when the syncope frequency is less than 1 per month, there is no underlying structural heart disease, and also the resting ECG is normal. It is implanted subcutaneously in the left parasternal region. Several registries and trials like the Charisma trial in post-MI patients and Crystal AF trial in the stroke patients with atrial fibrillation, they have showed the importance in unexplained syncope, and it gives the data for up to 3 years. In long run, it can be cost effective than multiple inconclusive non-invasive tests and multiple clinic visits. So in our practice also, ILR may come in the coming 5 to 10 years. Now this is important. If the frequency of symptom is daily, then 24-hour halter or in hospital monitor bed is sufficient to pick up the arrhythmia. If the frequency of symptom is less than that, then also extended 72-hour or 48-hour halter can pick it up. If every week, once a week symptom, then 7-day halter or patch recorder, external loop recorder, these things can be used. And if the frequency is less than 1 per month, then ILR is the only option to pick up the symptoms. Halter won't be of much help. Now electrophysiological study. We are quite interested in this part, but it has been given a class 2B recommendation in sinus bradycardia by ESC. And it is only helpful when the symptoms are there, if there is pre-existing syncope sinus bradycardia, but we cannot show a correlation between the symptomatology and the findings. Only then the electrophysiological study has got some importance, but we will discuss it. So EP study, it is preferred when there is a high pretest probability of associated conduction system disease also, like abnormal.
Yes, you have already taken nearly 30 minutes. So
wrap it up in 5 to 6 minutes.
Sure.
So abnormal baseline ECG, bundle branch block, presence of underlying ischemic heart disease, these are also helpful. In that case, the EP study is preferred. And HV interval more than 70, AV block during atrial pacing or Wenckebach point at a rate below 120 per minute, they point towards the associated conduction system disease. And what we actually calculate here is SNRT, sinus node recovery time, and SSCT, sinoatrial conduction time. So SNRT, it tests automaticity. There is a high right atrial lead near the sinus node, and a pacing is started at cycle length just shorter than baseline sinus cycle length, is continued for 30 to 60 seconds. After 1 minute, it is repeated at a shorter cycle length up to 300 milliseconds, not less than that. So longest pause from the last pace beat to the first sinus beat of the return cycle, it is calculated. Normally it's less than 1500 millisecond. In a patient with pre-existing sinus pause or syncope, sometimes the calculation becomes difficult because the junctional beat might come up in place of the first sinus beat of return cycle, but that is also diagnostic. And sometimes secondary pauses are also noted, that is that there is a recovery sinus beat, but after 1 or 2 beats the rate slows down further compared to the baseline. So the secondary pauses, they are also important, and SNRT or corrected SNRT more than 1500 or 550 millisecond, that is of value in predicting. It has got almost 35% to 65% of sensitivity, depending on the clinical scenario. And sinuatrial conduction time, it tests the conduction time out of the sinus node. There are many techniques, but Strauss technique and Narula technique, they are most frequently employed. I will not go into the details because there is a shortage of time. And this diagram I will explain in short. The Y represents the resetting time required to reset the SA node by a external stimulus from the high right atrial lead, and the second Y, it represents the time required for the impulse to depolarize the SA node and come out into the atrium and generate the third atrial impulse, A3. So Y plus Y, that is the total sinuatrial conduction time. So the actual sinuatrial conduction time is only Y, that is the gap between A2 A3 minus A1 A1 interval divided by 2, that is the sinuatrial conduction time. So how to manage? Acute management, as we all know, exclude the reversible causes, treat hypervagotonia, and sinus bradycardia is possible in trained athletes, so don't bother about that. And if the patient is asymptomatic, we can do an expectant management and keep a close observation. If symptomatic, then atropine as isoprenaline and temporary pacemaker. If hemodynamically unstable, these are the management options until the condition reverses or there is a necessity of a permanent pacemaker. And chronic management is definitely permanent pacemaker or watchful expectancy, whichever is appropriate or according to the patient preference. In asymptomatic patients, we don't need to do a ppm. In symptomatic, we definitely require it. So it has got no direct effect on mortality, but pacing improves symptoms and quality of life. It has been shown that dual chamber pacing, it reduces incidence of atrial fibrillation, stroke, pacemaker syndrome as compared to VVI, but DDD is not superior to atrial pacing or VVI in terms of mortality benefit. The DAN-PACE trial showed that increased atrial fibrillation and greater chance of reoperation for associated AV block occurred in AAI patients compared to DDD. So we prefer the DDD mode of pacing. And sometimes if there are atrial tachyarrhythmias associated, then we have to keep the atrial tracking off and enable an automatic mode switching. And we have to minimize the RV pacing by hysteresis and adjusting the AV delay appropriately. But however, too much AV delay, that can again give rise to pacemaker syndrome, diastolic mitral regurgitation and left atrial enlargement. And rate responsive or rate adaptive programming by accelerometer or minute ventilation, etc. This can be done in case of chronotropic incompetence. And atrial anti-tachycardia pacing algorithms may also be incorporated, but they are not as effective as ventricular anti-tachycardia pacing, which is used in the ICD. So symptomatic sick sinus syndrome, definitely a class 1 indication, but in others we have to individualize the patient according to the recent guidelines. And sinus node dysfunction after a cardiac transplantation, we have to wait for 6 weeks before deciding regarding the permanent pacemaker. And if there is a chronotropic incompetence which is symptomatic also after 6 weeks, then we can consider a rate responsive pacemaker in that particular patient. So some questions will definitely remain unanswered, like is there any role of chronic anticoagulation in atrial standstill patients, because they also have high incidence of thromboembolism. So there is no mention about it in the guidelines. And whether there is any role of permanent pacemaker if there is a persistent symptomatic sinus bradycardia after an AMI. Like AV block, the guidelines have said that it is 5 days, as early as 5 days we can implant a pacemaker if it is found necessary. But regarding sinus bradycardia, there is no mention when to use a pacemaker. So thank you everybody, and a happy Bengali New Year.
Thank you, Kuntal, for the exhaustive discussion on sinus node dysfunction. This is now, unshare your screen, please.
Sure.
This is now open for discussion. You have touched upon several points. There are questions in the chat box, one of which you have already answered, that whether a DDD a pacemaker, it prevents atrial fibrillation. One study showed it prevents, other studies did not. So there is a debate about it. Only one study convincingly showed that this reduces the incidence of atrial fibrillation, but other studies failed to replicate that result. That is one.
And these are small scale studies. They have not.
And none of them are very reliable. None of them are very reliable because it involved not too many patients. Well, Anyanda is here. Soumitra is here.
আমি একটা কথা বলবো,
I want their opinion.
আমি একটা কথা বলি কুন্তল, শোন, আমি হয়তো ডাক্তারি জানি না, সেটা তুমি আমার থেকে বেশি জানো। তোমাকে আমি একটা জিনিস বলি, যদি কিছু মনে না করো, দাদা হিসেবে। তোমার এত ভালো বলেছো, কিন্তু তোমার দুলবে না বলবার সময়, ফ্রন্ট টার্ন ব্যাক করবে না। হ্যাঁ, এটা আমাদের অনেকেরই হ্যাবিট থাকে। তোমাকে এটা কনসিয়াসলি সাপ্রেস করতে হবে, কনসিয়াসলি। হ্যাঁ, so that your body language is more relaxed, you stay calm. Your content আমার কিছু বলার নেই, সেখানে অনেক এক্সপার্ট লোকজন আছে, অনেক এক্সপার্ট লোকজন আছেন।
কোথায় স্যার? আমি তো পরীক্ষার সময় একটুও নড়িনি।
বরাবর ভুলে গেছি, বরাবর
পরীক্ষার সময় নড়িনি।
old habits die hard, কিন্তু একটু কেয়ারফুল হয়ো, that then আমার প্রেজেন্টেশনটা আরো বেশি এনহ্যান্সড হবে।
Arindam, Anyanda, please comment.
I joined quite late, so I didn't follow him from the beginning.
Okay.
But two things that I feel that which we practice, to what extent this is valid. First, I came across two cases, patient presenting with sinus bradycardia, halter, 48 hours halter, and other things were normal. There was no history of chest pain, no history of diabetes. But since I couldn't find anything more, and since I am not an EP expert, so I thought, let us do a coronary angiography. And the patient, because there was a slight ST elevation in AVR in treadmill test. Treadmill test was reported negative. And there was a left main ostial stenosis of 70%. After the angioplasty done, there was no recurrence of syncope, which was there before that, at least once a week. So I feel that in our country, particularly where incidence of ischemic heart disease is very high, if there is any possibility, or if there is any slightest possibility, we should go for the CAG angiography to exclude coronary artery disease. That is my practical experience. Secondly, a clinical test that we have been doing for years together, after we were excluding the carotid, if there is no narrowing of the carotid on both sides, what is the role of carotid sinus passage to evaluate the sinus node function as a primary test?
Sir, it mainly excludes the carotid sinus hypersensitivity if there is a significant pause more than 3 seconds. Previously, it was called as 4 seconds on 5 seconds of carotid sinus massage. But in sinus node dysfunction patients also, this reflex can be exaggerated, as the pause can occur by carotid sinus massage. So that way we cannot perfectly differentiate whether it's a reflex cause of bradycardia or there is primarily a defect in the sinus node itself.
Suppose a patient has a history of recurrent syncope. I have not gone for the EP study as yet. There is no apparent cause of sinus bradycardia like thyroid and other things or beta blockers. I did a carotid sinus massage and I found a gap of 3.5 or 4, which is symptomatic. Is that good enough to go for the pacemaker, or you want to do more tests and confirm it?
Sir, in our setup, I think since we cannot always elicit the perfect history, that whether there are some situations like shaving or whether a necktie or buttoning the collar, these things cause symptoms of syncope. Sometimes this history is not available in carotid sinus hypersensitivity. So if there is a definitely a significant pause and the patient is symptomatic, then the patient should undergo a pacemaker, because the lifestyle modification is not possible, because many of these things which give rise to the symptoms, they are essential things which you have to do in our day-to-day life. So you cannot eliminate them from our life. So it's better to keep a pacemaker as backup. Maybe a single chamber also if the patient cannot afford, but still a pacemaker is a necessity.
A very important question has been raised by Shuprativ and has been coined by Anyanda. The role of a coronary angiogram in patients with sixth sinus syndrome. Should we routinely do a coronary angiogram before implanting a pacemaker? What the guidelines say?
Sir, the guidelines, there is no mention regarding routine coronary angiogram. If we suspect that patient has got a coexisting ischemic heart disease, and if there are standard indications of doing a coronary angio like refractory angina or hemodynamic instability during angina, these things, or any electrical instability because of the angina, then we can go for the coronary angiogram.
So angiogram to be done in its own right whenever it is, we feel that it is necessary, but not routine.
No, sir. It's
perhaps the answer.
According to the
your
Yeah.
views and comments.
So I think we are running late. I'll be trying to be brief. First of all, I thank the organizers for arranging a talk which is less often discussed, but it is very commonplace and very often a common clinical problem. Particularly, maybe diagnosis of sinus node dysfunction or suspicion is not quite difficult, but when to pace or not to pace, that decision becomes very difficult, particularly as the life history of a sinus node dysfunction is very long. Maybe over implantation and under implantation of pacemaker, both are important. We may not be allowing a good quality of life if we are delaying too much, or if we are doing earlier, maybe it was not necessary, but we're doing it. So even if we look into the latest ESC guidelines, EHA also is there in the guideline regarding the pacemaker implantation. The indications are not quite clear cut. Often it is said that you have to discuss with the patient, with the patient's relatives, his lifestyle, availability of medical aids, etc., while before going for a pacemaker implantation. Maybe at times you have to be a bit early, particularly as Kuntal pointed out, as the medical facilities in our country is less, proneness to accident is more due to the traffic congestion, problems in the pavement, etc. Maybe we have to be a bit more careful, and early pacemaker implantation may be necessary. Another group of disorder I would like to think that needs discussion is fall in Parkinsonism. Now we know the nodal disease and Parkinsonism or like disorders are commoner as the age advances. So both may be associated or may be dissociated. So appropriate history taking and clinical examination are very important. And also certain autonomic dysfunction like Rayleigh syndrome and dysautonomia, postural hypotension, they are often confused and mixed with node. So we have to separate them out if we have to have proper management of fall and syncope. It is not just bradycardia related. There may be associated problems. One just important note of caution regarding evaluation of Holter. I'll ask a small question to Kuntal, then go ahead. Kuntal, what fallacy do you often get in analyzing a Holter that is commercially done in day-to-day practice?
Sir, one thing is that most of these are 3-channel halters, so we cannot exactly look at the P-wave morphology also. Sometimes they coin a particular beat as a supraventricular impulse, and it also looks like some. Maybe it's a P-wave only coming from a different region of the SA node. So there can be variations in the P-wave morphology. If it comes from, sometimes if it arises from the head of the SA node, the P-wave morphology is different from that which arises from the tail. So these things, they cannot identify, and they point it out as a supraventricular. And sometimes they point out a ventricular ectopic as a they point out a supraventricular ectopic as a ventricular ectopic. Maybe because of aberrant conduction, we cannot see the morphology.
Okay, let us be brief. I accept your academic points, but the most practical thing we miss in Holter, the patient's diary is missing. They are not keeping any diary, and often the Holter's clock and the patient's clock are not matched while implanting. So there is a wide discrepancy between the two clocks. So these things, I think there should be always a coaxing with the technician implanting that please do into the. I often ask the patients that you tell them to do these two things. One, ask to maintain a diary. Another is to adjust the two clocks. Another thing you rightly pointed out the importance of ILR. I have implanted some of them with good results. That is different types of arrhythmias and non-related. That means fall without relation to arrhythmia or syncope or pre-syncope without relation to arrhythmia, all are brought out. So these are important things. I hand over to Shantanu with thanks to Kuntal.
Thank you, sir.
I have a small,
any question?
Yeah. It was a fantastic presentation, Kuntal. In fact, it reminds me my MD days when we used to go to the seminar conducted by Dr. Guho 15 years back. So very meticulous, very nice presentation. I have a very small question. Many a time we come across the patients with chronotropic incompetence. We do TMT, but the heart rate do not increase even without a beta blocker. And sometimes, very rarely, we do find patients during TMT some degree of AV block, either a 2:1 heart block or a complete AV dissociation, without any history of syncope. In fact, I do have 2 such patients where some of the cardiologists they advise for permanent pacemaker, but I did not do a permanent pacemaker. They are in follow-up. So what is the current status of treating chronotropic incompetence and this kind of AV dissociation in TMT? Is there any guideline or recommendation?
In the AV dissociation during TMT or during exercise test, there is a guideline. It's a 2A indication if the AV dissociation is high grade AV block, and it's not a class 1 indication. It's a 2A indication as per the ESC 2021 guidelines. And also chronotropic incompetence if it is associated with symptoms of bradycardia after the exercise, that is a class 2A indication. If there is just chronotropic incompetence and no syncope or pre-syncope, only exercise intolerance, then as per ESC, it's 2B indication. This is the current status.
Is there any definition of chronotropic incompetence? I mean, how do we define chronotropic incompetence?
It is, I have already mentioned it. It is the age predicted maximal heart rate. It's up to, the patient can achieve up to 70 to 80%. If the patient cannot achieve more than 70% of that, then definitely is chronotropically incompetent. But the suspicion should arise if the patient cannot achieve more than 85% also. But less than 70% is definitely chronotropic incompetence. It has been defined variously in different literatures. What I have collected is that at some places it's written 85%, somewhere it's written 70%, somewhere 70 to 80%.
One question.
Yes, sir.
Chronotropic incompetence only doesn't produce syncope. That question is not, it is not that important. Rather than patient has an exercise intolerance, they cannot do exercise, that quality of life deteriorates. That becomes far more important in this patient. So yes, what is the conclusion on this particular issue? There is no syncope. There is absolutely no syncope, but the patient's exercise tolerance has come down.
Exercise intolerance and documented chronotropic incompetence, that is a class 2B indication. That's not a class 1 indication or class.
It is not class 1, of course, but I just sometimes we are forced to put in pacemakers because of this, and the patients do they're definitely better with this. But if it is done in a very selective patients, well selected patients, definitely the patient's quality of life improves. So that's why I thought, what is the present status of that particular indication? Any other question?
I think Dr. Kormukar wants to ask a question.
Rothen, please.
Good evening, everybody. First of all, Kuntal, thank you for your nice presentation. And after a long time, I'm hearing you. Hello. I just wanted to one thing. Nowadays, some smartphone, smart watches are available where ECG can be recorded. So how far is it is medically valid? That's my one question. So far, my knowledge, last year ESC guideline didn't incorporate in their guideline. So how to handle? Sometimes patient come with the phone and saying this happened. So how to deal with this?
Now, smartphone-based applications and smartwatch-based applications, they have been mentioned in the 2021 supplementary data of the ESC guidelines regarding devices. So,
But still, Kuntal, there is still a controversy about what to do with such data, how to act on those. If you get a 24-hour save, that's fine. But if you get a 1 minute, 2 minute save by your smartphone, how to act on that, it's still very debatable.
and
So
when
it's,
the patient
at the moment, it's producing more agony than any solution of the agony.
Yes.
So I don't think it's a proper time to use it or to recommend it.
Yeah, for atrial fibrillation, it may
Yeah.
not be a proper time, but for complete heart block, if you can document
Oh yes.
AV
Oh, yes.
dissociation or a very
Oh, yes.
long pause of more than 3 seconds in symptomatic or more than
Yes,
6
yes,
seconds
yes.
in asymptomatic patient, it may give some value to the treatment
That's
protocol.
true.
That
That's
part is definitely relevant. That part is relevant,
That's
but the
true, yes.
atrial fibrillation, not only from the smartwatch, also from the other pacemakers and other devices which has an halter, there's a high rate episodes. There is a debate about this, how to act on it. Anyway,
In
Kuntal,
newest edition, Rothin, of the Brownwell, you will get a chapter on wearable devices. That includes the discussion on smart watches also.
Yes, sir.
Thank you for raising this issue.
Yes. Just, sir, we see the quality of the ECG is pretty good because all the morphology of even small p's are seen quite well. So as Arindam was saying that if we can document a heavy, there is a complete heart block or severe brady, that is just I think it's sufficient to get a decision.
thanks everybody for this wonderful and exciting discussion and a wonderful presentation. Next, I will request, for the sake of time, we have to stop it here. Arindam, you are ready?
Yes, sir. Yes, sir.
You please start with your presentation.
Yeah, I'll be showing a case, so I don't think it will take long. So I think
let us discuss. That is the purpose.
Yeah. So I think my skin is visible.
Yeah, it's visible.
Thank you. So coming to the case, my patient was a 73-year-old gentleman who had very advanced interstitial lung disease for which multiple inhalers, immunosuppressive medication. Now, he happens to be the father-in-law of a reputed gynecologist of the city, and he was rushed to emergency with a history of on and off chest pain for last 3 to 4 days with very increased intensity for around 4 to 5 years. On emergency, the pulse was 110, saturation was 93%, and he says the saturation remains in that range only because of very advanced ILD of the patient. Now, blood pressure was 110/70, so not much of hemodynamic instability with a respiratory rate of 32. Now, on further evaluation, ECG revealed a bifasicular.
Arindam, your slides are not changing.
Oh,
Make it full screen.
I did so. I'll do it again. So, is it visible now? Is it visible?
Yeah, it is
Yes,
now
yes,
visible.
yes.
Yeah.
Right.
So can you go back one slide?
Yes,
Clinical
I'll
features.
Yeah, this is the clinical features. 73-year-old gentleman, advanced ILD, chest pain on and off for 3 to 4 days, increased intensity 4 to 5 hours, rush to ER, heart rate 110, blood pressure 110/70, saturation 93, respiratory rate 32. So with this background clinical information, we did further evaluation at emergency department only. ECG revealed bifasicular block. TROP-T was strongly positive and quantitative TROP-I was 12. Echo ejection fraction 50% with wall motion abnormality in anterior lid, LV wall. And the chest X-ray was very typical. I can show you the chest X-ray. The lung volume is shrunken and very characteristic features of interstitial lung disease in this patient. So at this point, we took him for angiography because of very strongly positive troponin card test and elevated troponin I hope the angiogram is visible. We can see the LAD is having a nasty calcified lesion, left dominant circulation. left dominant circulation. So the angiogram was done in radial route with a 5 French catheter, TIC catheter. While doing the angiogram, first thing which happened, because baseline hemodynamics was all normal, 100 blood pressure, but after engagement of the left main, the blood pressure started falling. So we thought probably along with the left main, there is some issue with the, along with the LAD, nasty calcified lesion in the LAD, probably there is something in the left main as well. So in cranial view, we can see the left main ostium probably is having a stenosis. We cannot see a proper backflow of dye. So this is a 5 French catheter. So ideally there should not be any pressure dam, and backflow is very easily visible. So we thought probably there is some significant left main ostial stenosis. So what we did, we withdrawn the catheter and did a non-selective angiogram. With non-selective angiogram, the left main ostial lesion was visible clearly. So at the end of angiogram, this is the right coronary system. This was a non-dominant vessel, but diseased, but not a big vessel. So probably not of much concern. So the case had two issues. One is advanced lung condition in the form of interstitial lung disease, along with a left main and a nasty calcified lesion in the LAD. So a medical board was formed. So in my hospital, there is a heart team which is in play, and so heart team approach. The decision of the board was that the bypass surgery was first revascularization option for him. But due to presence of advanced interstitial lung disease, the perioperative ventilation management and weaning was considered at very high risk, and there is high possibility that this kind of patient, they may become dependent on ventilation, and it may be very, very difficult to wean the patient. So an option of peri-procedural, initially the option of impella was given. We know in our city, Dr. Hajra has already done one peri-procedural impella, but impella is very expensive. Around the cost is around 25 lakh for impella itself, bearing the cost of angioplasty. So that was prohibitively high cost. So we thought, let us go for a alternative. So a peri-procedural VA ECMO guided IVAS supported PCI, ideally with intravascular lithotripsy, because LAD was seen to be very calcified vessel. So that was our plan, LAD to LMCA angioplasty. So this option was given to the patient's relative, but again, IVL, angioplasty, IVAS plus ECMO, the cost, total cost was very high. So it was not acceptable by the patient's relative. So we thought, let us do IVL. We did not include IVL in the management protocol. We thought high pressure balloon will do. So VA ECMO was considered ideal in this patient because it was it will give a very high good circulatory support, as well as it will alleviate the need of mechanical ventilation. So the idea was to do a awake angioplasty with a ECMO, VA ECMO support. So that was the idea. So with that idea, we went ahead, and we can see the ECMO, the venous port of ECMO. We can see in the right atrium, the venous port is seen, and this is the arterial port of ECMO. You can see the arterial port on the left groin. And at the same time, we can clearly see the 7 French additional arterial seat, where the puncture is done in the opposite direction. So this actually is to keep the lower limb perfused, because many a time it has been seen there is a chance of ischemia of the left lower limb from the arterial side. So to alleviate that, 7 French arterial seat was punctured on the opposite direction, and the job was done from the right groin, 7 French femoral axis. So that is how we took the support, and then we went ahead with the angioplasty, 7 French femoral. This was a JL guiding catheter, and as many newcomers are also there in the audience list. So whenever we approach a left main, we should ideally keep aware in the sinus, coronary sinus. So that helps preventing the guiding catheter to suck in. So the chance of hemodynamic instability and dissection of the left main can be taken care of. And the lesion was very tight. So IVAS catheter actually did not go through the tight lesion of the LAD. So we pre-dilated with a 2 millimeter semi-compliant balloon. And after that, we can see the IVAS catheter went in the LAD, and we did a IVUS which showed a very significant calcification, both adventitial as well as intimal calcification. So distal artery was around 2.5 to 2.75, and now we can see the calcification. There is 180-degree calcification, intimal calcification, very tight lesion, and at some point actually there was more 270-degree calcification as well. And I'd like to focus at this point the ostium of the LMCA at the last part, shown to be a very significant stenosis. It was around 70% stenosis, the ostium of the left main. So that confusion also was alleviated, the use of IVUS. So we further pre-dilated the lesion, LAD lesion, with a 2.5 millimeter non-compliant balloon. But unfortunately, while doing the pre-dilatation with the NC balloon, the balloon got torn from the shaft. So that was a complication which we encountered during the procedure. So what we did, the assembly was trapped with a 2.5 millimeter balloon and removed as a single unit, as is the standard practice. Then we had to rewire. And this time we took a OPN-NC 2.5 millimeter balloon. And I'd like to, ask everybody to focus that we have taken two guiding wires. So this is how we do it whenever we take ultra high pressure balloon, because now the balloon is being inflated at a 35 atmosphere pressure. So at that high pressure, many a time the balloon actually stucks with the wire. So it is always better to take it through additional wire. So two wires, the other wire can be kept because there is high possibility of dissection after that high pressure balloon dilatation, and many a time renegotiation or rewiring becomes tricky. So two wire, one of the wire will have this OPN-NC high pressure balloon, and we did a thorough pre-dilatation with the OPN-NC balloon at 35 atmosphere. And after that, a distal stent of 2.75 by 33, and that was post-dilated with a 3 millimeter non-compliant balloon. Then we took the we actually post-dilated the stent, and this was the result in the LAD. The diagonal, very important, two big diagonals are all patent. So that is the beauty of proper pre-dilation and bed preparation. Then we did direct stenting to the left main ostium. As in IVUS, it was shown that there is hardly any calcification, but the lesion was tight. So this was a 4.5 by 12 millimeter drug-eluting stent in the osteoproximal left main, and we can see the ostium is covered. Then we did flaring of the left main stent with the same stent balloon. This is how we do it. Just withdraw the balloon a bit, then again inflating it at high pressure. So that is how the procedure was done, and post-stenting IVUS was done. I'll show it at the later part, and this is the final result. We can see the left main and the LAD. Patient's chest pain was alleviated, and he's doing good. Actually, he's doing good, and this is the team. So ECMO support withdrawn next day only. Patient went home third post-operative day, came for follow-up after 2 weeks. Now it is 6-month follow-up. The patient is doing fantastic. No recurrence of angina. The case actually indicates the importance of proper planning and interdepartmental coordination. Thank you very much. I will stop here for some discussion.
Thank you, Arindam. Excellent case, and very well performed, despite having the initial hiccup of you did it very well. It is open now, open for discussion.
Shantanu, I am speaking, Arindam.
Please.
Yeah, Arindam, first of all, congratulations. And you have shown the issue of team management. But initially the planning, then execution. Both are done by the team. That is very important. And the interventionist feels comfortable when there are other people to manage the patient and he can focus on the technical issues. You have also shown the importance of taking a JL, as you mentioned that you are discussing for the newcomers also. So why not an EBU and why a JL besides the wire in the sinus? That also has to be discussed. I think you covered that. The issue is, first of all, I have a question whether you consider this scoring balloon over the very high pressure balloon. Do you find any advantage or disadvantage between the two?
Yes, sir, it's very relevant question. Nowadays, we do have a very good scoring balloon in the form of Wolverine balloon from Boston Scientific. But the problem with Wolverine balloon, the availability, many times the supplier, they do not make it widely available. One problem I'd mention about the scoring balloon, they are very bulky. So they are very bulky. So to negotiate the scoring balloon, I personally feel OPNNC has a better, deliverability. OPNNC
What was the length of the balloon taken?
In this case, I took a OPNNC 2.5 by I think 8. I think 8.
I don't think it won't have been very bulky in this particular.
Yes,
but
yes.
if it is a longer balloon, yes, it is a genuine problem.
Yes.
Yeah.
So one of the disadvantages of the scoring balloon is the bulky nature of the balloon. So many a time, if the calcification is very, very severe, then there might be some difficulty in negotiation. Though my case ideally I should have taken a rotablation or IVL, because there was at places and I was clearly shown that there was almost 360-degree calcification, very tight calcification. But overall budget we had to
we have a limitation in that. Another is I missed that point. What was the circumflex ostium? Because circumflex is a big artery.
Yes.
After
yes,
the procedure, after 2 stenting, what was the circumflex ostium?
So first of all, it was a dominant circumflex, left dominant circulation. That is why I took a hemodynamic support, because during angiography only the pressure started damping. So very importantly, it was only the left system, right coronary artery was of no use. So I was pulled back, clearly shown beforehand that there was hardly any lesion in the ostium of the left main, and my stents were actually not taken at the LAD ostium.
So it was spared.
Yeah, it was spared. The left main stent as well as the LAD stent, none of them actually enclosed the circumflex ostium. So there was no issue with that.
Okay, thank you so much.
Arindam, thank you very much for a very excellent case. You had 2 wires in LAD, isn't it?
Yes, sir. Yes, sir.
You had your own justification for that. But there is an interesting story about it. They say that this is a poor man's cutting balloon. If you have a second wire, apart from its proper guiding and other things, it might also help you to open up the calcified lesions when you cannot go for cutting balloon and other devices. So when you do like this,
Ananda, basically this is taken as a very popular conjecture. But if you think the diameter of the wire and the diameter of the inside of the lumen, I don't think this is an important issue. And that wire doesn't travel from this place to this place. It remains in a single line.
This terminology has come from the rich man's country, not from the poor man's country. So even there, they have done it. It's something it might work. I mean, if there is
it is applicable for ostium only.
No, not any calcified, non-calcified hard lesions. When you cannot go for other things, you might try again, because there is no harm in it. A wire is always safe.
Subra, you are in India or UK?
You are Banerjee, I think he is in his meet.
Yes, here is Shubhra.
You are mute.
Now I'm in the UK now.
So any comments? As I have,
sorry,
yeah,
I just
international comment.
Western comment.
Poor man's rich country, ei duto shunechi ar ki.
Okay. Any other comment?
The comment is that we should take lesson from the fact that if and whenever possible, we should do a coronary angiography for a patient presenting with bradyarrhythmia or heart block, AV or sinus node disease, whatever be it, angiography should be kept in mind.
Yes, sir. In my practice, my threshold for doing angiography for all my pacemaker patients is very low. Particularly if they are more than 60 years, I do make a point to advise them. Yes, many of them do not do it, but I always advise.
How long the patient was kept in ECMO?
1 day, sir. Only 1 day.
1 day. And the arteries and veins, they were quite
all
okay.
Good, sir. All good, sir. All
Okay,
good. Third post procedure day, I discharge the patient.
Very commendable job.
But can it be recommended as a routine for all pacemaker patients to have a check angio before pacemaker? which is being done in certain hospitals.
I do it. I accept it. I do it.
There is no guideline for that.
It is not there in the guideline.
Yeah.
It is not there in the guideline. ESC 2021 didn't recommend that thing. They are silent on this issue. So,
is there any rationality to do it for all patients? I mean, maybe patients who get chest pain has high risk of coronary artery disease,
absolutely,
elderly.
But as a routine,
No,
I think whatever we discussed this issue in the first case itself, if the patient needs an coronary angiogram in its own right, of course we should do it. Otherwise, it should not be done as a routine.
And another issue, Shantanu, is that angio is a anatomical imaging.
Delineation.
It doesn't. It is a very commonplace to have atherosclerosis in the coronary artery in an older person.
It only adds to the confusion.
But whether that needs intervention or not, whether that needs only medical management, that becomes an issue. So we can do that on technical ground. I mean, clinical ground.
Yeah. Any other comments or questions? That's a wonderful case. Ovate.
Sir, I have one question.
I think everybody's jaw has dropped, so nobody is making any comment. Arindam.
This is a very unique case. I don't think I may get another chance to see such a beautiful case in lifetime. So this is a nice case. Congratulations to Arindam. So I just wanted I had one query. You used VII ECMO. I didn't see. I think I may have missed. You didn't use the IVP during procedure.
No. IVP I didn't use, because if you use VII ECMO, you don't need a IVP.
Okay.
Because it will serve the purpose of both, the pressure support and all. They have something during procedure. Whenever my blood pressure was falling, they were just giving some fluid, extra fluid, and by that only the blood pressure is going up.
So it has got hemodynamic as well as ventilatory protection.
Yes. And patient was awake. He kept on talking. Even the blood pressure failed. Whatever happened, and saturation was not an issue. So it take care of both lung and heart.
Okay, and it's primarily meant for oxygenation, and secondarily you're saying it is also it helps in keeping the blood.
No. If you do a VV ECMO, that only takes care of lung part. So that do not give support of the heart. So blood pressure is not taken care of. But if you do a VA ECMO, that takes care of the blood pressure as well.
What was the cost of using it? For say, you used it for 2 days.
Yes, I used for 1 day only. So it was additional 2.5 lakhs only.
And what is the cost of using an IABP in your hospital?
So it is lower. IABP is around 70,000. Around 70,000.
Yeah. It's much cheaper.
Yes, somebody has raised the hand.
I think Rothinda only. Rothinda, you kept raising your hand.
Okay, sorry. Okay.
Any other questions, comments, anything? Shupratip? Shotten?
No, sir. It's a complete case, and it's a pleasure to see the case. No comments.
No comment.
No comment, sir.
Just another
just one thing I like to ask Arindam da. One thing, sir.
Go ahead.
Go ahead.
Do you feel any difficulty if you do you like to use rota in this case?
Yes,
because there is a osteal lesion in LM. So will there be any difficulty
as I had planned for stenting the ostium of the ligament as well, so I could have used rota, no issue, because even if there is some dissection or something like that, I do have a hemodynamic support in place, and after the LAD is done, then I could have stented the left main, so I'll have the time in hand, because VA ECMO is like a complete bypass, it will take care of all the things, so I can use rota in this case. Ideally, I should have used, but due to some technical issue, I could not use it, but rota would have been ideal. Both adventitial and very significant intimal calcification was visible in this thing, IVAS. In fact, the calcification was so severe. One of the balloon, it was a New York balloon. While removing, it got torn. So very significant calcification was there.
Shubhra, any comment? You are mute.
Dr. Banerjee probably didn't see the case, so.
That's right. I didn't see the case. I've just been hearing the end part of it. But what it appears to be that Arindam has really presented a beautiful case. And I'm sure he's going to present it sometime again so that I could be able to see as well.
Your Prime Minister is coming here.
Good. Any questions, comments, or any suggestions?
I am joining here for the first time. I have enjoyed a lot, learned a lot more, and
Yeah,
thanks the organization for this. And I'll be continuing to joining whenever time and opportunity permits. With this, I'd like to conclude for myself.
Thank you, Arindam. Thank you very much.
Thank you, Shantanu, and your
Shubho
Arindam.
Navabarsha, virtually to everybody.
Shubho Navabarsha to all my teachers.
Shubho Navabarsha.
Many teachers, many of them are there. Thank you very much.
We will have this meeting again after 2 weeks.
One thing, Shantanu, you make it please see to it that all of us get the information about that subject to be discussed. 7 days.
Yeah, subject 7 days. You wanted 7 days before.
That's 7 days.
Okay, like fine. Fine. I will see to it. I'll see to it.
So what's the next date?
2 weeks. We are doing it on Sundays, every 2 weeks.
A fortnight program.
So is it next session is May Day?
Maybe if it is, it should be around that.
On May Day, I think May 1.
So
no problem.
We will have it done. And who will present here? Rajoshi is there and Shotten is there. One of you will present.
I think Rajoshi has left.
Rajoshi, Shotten, you are here or you have left?
Shotten
has also. Either of them will present a case and Spandan will speak on SGLT2 inhibitors in cardiac practice. Spandan?
SGLT2 inhibitor on?
Yes. In cardiac practice. Just is not in heart failure specifically. He will broaden the subject. What are the other users?
I will discuss about SGLT2 inhibitors, its scope in cardiology practice, its mechanisms, etc. The relevant points.
That will be good.
It will be, your time will be 30 minutes. So please prepare your talk accordingly.
Okay, sir.
So that we have some at least 15 minutes time for discussion. This is a very hot subject and I think this will invite a lot of discussion.
Yes. So just last week, ACC, I think I missed the name of the trial. The empagliflozin had been found to be very useful in acute setting also. So it is
Emprise trial.
Yeah.
Emprise trial.
And it has been shown, this is perhaps the first drug which has shown to be beneficial in HFpEF. This became statistically significant.
Emperor preserved, yes.
Yeah.
Yes.
Okay.
So let us discuss these things in the next day, and either Shotten or Rajoshi, either of them will present a case. So
okay, thank you very much. Good night.
Thank you very much.
Good night, everybody.
Good night, everybody, and good night. Good night.